We'll wrap up musculoskeletal and do some ER practice on Monday. Okay. There are 2 things in there that are recorded. So if you can't hear them or you can't whatever, I can fix that. Again, Canvas gremlins, like sometimes when I pull it over it works, sometimes when I pull it over it doesn't. So just kind of give me a little feedback on that if you don't mind, and we will tackle all that stuff on Monday, okay? And like I said, I'm going to look at probably Monday for MedCalc retake if you need it. Okay, just put a little bug in your ear so you know what you're doing this weekend, okay? All right, so I'm going to do. Good? Anything else? Terrible? Okay. All right, then I will turn it over to you.
And then my friends that are sitting on this side, if somebody wouldn't mind just like periodically checking my camera, making sure that it still says recording on the bottom.
I'll sit over here.
Oh, thank you. I appreciate it. Thank you. Because I don't want to be like, oops, half my presentation's gone.
I need a job. Let me just...
You see the little countdown on the bottom?
Record. Got it. Yes.
Okay. Perfect. So I am Casey. I went last semester with you guys, and I did a class with you, so I'm back again. I hope that's exciting for some of you. I see some of you in my unit in Tampa General. I work on the neuro ICU, so I've seen a couple friends up there. So if you're up there, please come say hi. I'll try to share some cool things while you're up there. But yeah, so let's get started with our musculoskeletal system lecture. We're going to be talking about bones, joints, ligaments, tendons, and cartilage, and some basic assessment skills that we're going to need to take care of our patients. So the first thing, I know you guys are really flustered after your test, so I just put a little cute graphic in there for you. You can see an x-ray of Kermit the Frog. And what I'm about to tell you is going to change your life forever. Are you really sure you want to know? Sorry if that's a little corny, but I found this humorous. I'm really funny. All right, so let's start out with our cortical bone structure. You can see here in this picture that this is going to be showing us the compact bone, showing the Virgian system. So this actually makes up the shaft of your long bones, like your femur, your tibia, fibula, and your humerus, and also the hard outer layer of your bones. This part of your bone actually has poor blood supply, and when it gets to the outer ends of the long bones, where I'm going to pronounce this wrong, cancellate.
Oh, the calcaneus?
Calcaneus.
Yeah, oh, okay.
The rich blood
Yes,
supply.
gotcha. Okay.
So here is a picture of a long bone for you, and you can see that kind of spongy part on the cancellous bone, and you've got your different marrow cavities. You have the compact bone, which we were talking about with the Phrygian system. You have your periosteum. You can see the blood vessels in there. And we're going to get into the different kinds of cartilages and joints and things that we're going to see with the bones. So this chart here, this is basically going to tell us about the different kinds of joints we have in our bodies. This is also in your textbook if you want to kind of get more into it. But if everybody kind of thinks about the different joints in your body, your hinge joint, that's going to be your flexion and extension. So that's like your elbow. So you can flex and extend your elbow. You have the ball and socket joint, so that's like your shoulder, and that's going to give you that abduction, adduction, circumduction, so you can bring your arm all the way around, and also it's going to give you flexion and extension. Your pivot joint, so that's going to give you that rotation, so that's your tib-fib, and you've got your condyloid, which is flexion, extension, abduction, adduction, and circumduction. This is like your wrist joints. So I crack whenever I do this. Sorry if that grosses anybody out, but that's going to give you this motion here. You also have your saddle joint, which is like your thumb, and if you move your thumb around like this, you can see that's got that circumduction, adduction, flexion, extension, and then also your gliding joints, and they are going to be moving over the surface of one another. So you might not necessarily be able to feel that, but that's going to be like right on top of your hand. So joints are also called articulations. They are a place where the ends of 2 bones are in proximity and they move in relation to one another. They're actually named according to the degree of the movement they allow. So your hinge joint, that's why it's called a hinge joint, because it can go up and down, or your ball and socket joint, because it looks like a ball and a socket. The most common types are freely movable joints or diarthrosis joints, and each joint is enclosed in a capsule of fibrous connective tissue, which joins two bones together to form a cavity. The capsule is lined by the synovial fluid, so that's going to make sure that we're really lubricated in those joints that allow us to move, and that's going to reduce the friction. So the ends of the bones are going to be covered with cartilage, and that's kind of your cushion that's there, so that nothing's rubbing right on top of one another. And your ligaments and tendons are going to reinforce that joint capsule that's there, and it's going to provide limit to that joint movement. So I can actually hyperextend my elbows, so mine aren't as tight maybe as some people's are. So here's a good graphic of your ligaments and tendons. You can see that the areas here where they are connecting, they are composed of that dense fibrous connective tissue, and those bundles of the collagen fibers are really packed close together, and they're on the same plane. So that provides additional strength for that. Your tendons are what attach your muscle to your bone, and your ligaments are what attach your bone to your bone. Does that make sense? Your ligaments are going to have a higher elastic content than your tendons will, and they're going to provide stability while you're moving. We know a lot of athletes that when they get hurt, they tear their ligaments or their tendons or things like that. So that's why, you put a lot of wear and tear on these. They can stretch, snap, all really terrible things that are really important for the movement of our muscles. If you do actually have an injury in these ligaments and tendons, they actually have a really slow recovery time because they are not having a lot of blood supply to them. So that's why it does take so long, and unless you're a pro athlete and are able to go to physio every day and able to really take care of yourself, it does take quite a long time to heal. The fascia, this is going to be the layers of connective tissue that's going to be intertwined with the fibers that can withstand the limited stretching, and this is going to provide strength to your muscles. So your superficial fascia lies immediately under your skin. Your deep fascia is going to be that really dense fibrous tissue, and that's going to surround your muscle bundles, nerves, and the vessels. It's also going to enclose individual muscles, allowing them to be independent and glide over each other during contraction. And like we said, they do provide strength to the muscles. Your bursa, sometimes people may have heard of bursitis. Yes? Okay. So this is going to be small sacs of connective tissue, and they're going to actually contain that synovial fluid. They're located at the bony prominences or areas in your body where your tendons, muscles, and bones have a tendency to rub. They will relieve the pressure from that. So it's going to prevent friction, and then if you have any kind of inflammation in that bursa sac, then that's going to be your bursitis, and it's actually quite painful. So let's do our first eye clicker question. Your code's AA.
You can just close that window if you want. I think it'll. There you go. All right, good.
So which of the following joints do not provide flexion and movement? I'm pretty sure it's supposed to be flexion and extension. Sorry.
Oh my gosh, that's how I read it when I.
Yeah.
Sorry.
I didn't realize it didn't say extension until I read it out loud. I see some people like moving parts of their body around, and that's like totally fine. You can certainly do that. Got anybody left? Give them another couple seconds. All right, everybody. submit? Good job. Okay, so the answer is your pivot joint. And if you think about your hinge joints, that's going to be, you know, like your arms, you can go up and down like this, your ball and socket, like your hip, you can do flexion and extension with that. Your saddle joint, like your thumb, remember you can move our thumb all the way around and kind of wiggle it everywhere, and it goes in and out for flexion and extension. But your pivot joints are giving you that rotation, so they're not going to be providing flexion or extension for you.
If you push B again, it'll make the chart go away. Perfect.
Okay. All right, so our second eye-picker question. This connects bone to bone and prevents dislocation.
Got it.
Got it, that's the first one. I think I had 48 at the last one. Did everybody answer? Let's see. So we have B. And B is the answer. Good job. So remember, our tendons are what connect our muscle to our bone, and our ligaments are what connect our bone to bone. Does everybody understand that? Okay, so now we're going to talk about the effects of aging. So as we get older, things tend to not work the same as they did before. So when you get a little bit older, you are going to have some decreased muscle strength and bulk. So, you know, sometimes when people get a little older and they stop working out or they're not as active, they can look a little smaller in their muscular areas. They could have flabby muscles or slow reaction times to things. So we wouldn't be as quick as we would be as a much younger population. Your joints, anybody hear their grandparents say, oh, my aching bones, my joints, everything cracks, everything hurts. So you're going to get that joint stiffness, possible crepitation. So if you guys remember what crepitus is, it's kind of a similar thing. You're going to get that cracking and that popping on movement. Your pain with motion or weight bearing. Sometimes when older people get out of bed in the morning, they kind of take those first few steps and it hurts, it hurts, it hurts. Loss of height. So if you ever think of older people shrinking a little bit, they do kind of look like they're getting a little bit smaller. And that's going to promote some of that posture change that you'll see. So sometimes they're a little bit hunched over or they don't stand quite as tall. So again, with that loss of height, they're going to have back pain, decrease in bone density. So we have to worry about how fragile they are. So we have to take care of our older friends. So range of motion, so this goes back to our joints. If we're going to be doing active range of motion with patients, we are not going to be doing anything. They're going to be doing all of that on their own. So that's, you know, we'll say, okay, raise your arms up to the sky, and they're going to go ahead and do this for you. Or, okay, now bring them down for you. If you are going to be doing passive range of motion, then this is somebody else moving those patients' joints. So when, you know, I work in the ICU, so a lot of times when I get my patients ready for the day, I'll do my assessment on them and say, okay, now we're going to raise your right arm all the way up, and we'll stretch that arm up nice and high. And sometimes that's, you know, kind of painful for them. So you have to make sure that you're not putting them at risk for injury. But doing this passive range of motion is actually going to help them further along because you're going to get that muscle atrophy, and you can actually get some contractures, which we'll talk about in a few slides, if they don't do that passive range of motion. If they do start having extreme pain, we do want to stop immediately. And if you're meeting some resistance, you don't want to ever force the joint or the muscle to keep going. So this is a photo of again, with the goniometer. Yeah? Okay. So this just measures the angle at which your joint moves. Some people can probably, like I have hyperextended elbow, so mine would be a little bit bigger than another person's, but it just measures that angle. So your movement at your synovial joints, everybody stand up. We're going to do a little exercise. You're all going to feel really good after this. because you all look like you're so tired. So when you're going to assess your synovial joints, you can do 7 movements for the assessment. So we're going to do abduction. So for abduction, we're going to put our arms over our head. Good. And then adduction. We're going to turn our palms in. Good. And then flexion, drop our elbows back. Extension, straighten our arms. Oh, this is fun, this is what Simon says. We're going to do external rotation. We're going to put our hands behind our head. We're going to do internal rotation, and we're going to go ahead and turn our hands, put them behind our low back. And then hyperextension, clasp your hands behind you and stretch them back as far as you can go. That's your parallel. Does that feel good? I mean, that's awesome. We should do that every class. Okay.
Morning workout.
Morning workout. So that's an easy way to remember what your joints are doing. So, you have your adduction, abduction, inversion, extroversion. So it's an easy way to remember. You can sit down. So next we're going to talk about our muscle strength scale. So working in neuro, I do this quite a bit with my patients. You can do this with any patient just to kind of get their baseline. After they've had any kind of an injury, whether it be a skeletal muscular injury or whether they've had a neurologic injury or just had regular surgery, you do want to make sure that you are getting what their baseline is before and after that. So if we're going to grade the patient a 0, this is no detection of muscular contraction. So this is like saying, okay, squeeze my hand and I'm not doing anything. So it's not, like a little flicker or anything, which would be a 1. This is 0, not doing anything. So if we're going to give them a 1, say, okay, squeeze my hand, and they're going to, try a little bit to squeeze that hand. They're going to try and bring those fingers in. So if you're going to give them a 2, it's active movement of the body part with elimination of gravity. So if I want my patient to be able to, bring something up, maybe they can't lift this upper part, but they can move the lower part of their arm. So if I hold their arm up for them, I'm eliminating that gravity. I'm saying like, okay, can I help you do this? 3, active movement against gravity only and not against resistance. So, they're able to lift their arm up a little bit, but if I say, okay, don't let me push down on you, they're going to let me push them down. A 4, active movement against gravity and some resistance. So, they're going to push me back a little bit when I tell them don't let me push down. And for 5, that would be full, like I can go up to any one of you and say, like, okay, don't let me push down, and you're probably going to wind up pushing me away. So you can go anywhere from 0 to 5, and it doesn't have to be equal on both sides. We want it to be equal on both sides, but again, in a normal person, without any disabilities or any kind of injuries, they're most likely going to be 4s or 5s. Sometimes at work we give people old people strength. That's not a technical term, please don't write that on your desk. But you can, when you're a little bit older, you don't have as much of that strength that you have when you were younger, typically. And so they might be a 4, and that might be their best, and that's fine. But if they had any kind of a stroke or something like that, they could be a 5 on the left side, and they might be a 1 or a 0 on the right side. So it's important to remember to do both.
Can you explain 2 again?
Sure. So when you have your active movement of a body part with elimination of gravity, so you're going to be like making that gravity go away for them. So if I'm going to pick up their arm for them, and then they're going to be able to do some kind of a movement. So you're not making them fight that gravity that's pulling them down. You're going to take that away for them, and then they're going to be able to do some things. Does that make sense to everybody? Okay. So some of the assessment abnormalities that you'll see, one of them is atrophy. This is also, my fiance comes home from the gym and he says he gets swole at the gym. I don't know if anybody else's friends or whatever, they say that their muscles get so much bigger when they go to the gym and they come home and they're looking at themselves in the mirror because they have that big muscles and everything. So you have your active muscles that look nice and big, like in this picture on this side, and then you have your inactive muscles, which they're going to be, they're going to look thinner, they're going to be much weaker. So that's going to be your atrophy. You get this atrophy when you don't use the muscles as much. So this is actually the shortening of those muscle fibers because you're not using them, so they're not being stretched, they're not being built up. Contractures, like we were talking about before. Has anybody seen a person that has a contracture? Yeah. Has anybody not seen a person with a contracture? Okay. So this is a good example of somebody that has a contracture. He's not just holding his arms like this because he feels like it. He actually cannot move them away from this position. The joints and the muscles rather, the muscles and the tendons and the other tissues around there, they shorten and they harden. So it becomes very difficult to move through a normal range of motion because of those shortening of the muscles and the tendons and all those fibers. People that have MS or Parkinson's and sometimes even RA can have this, and it's going to be, you're going to go into your patient and you're going to say, okay, let's try and extend your arm, and you'll pull down on their arm and their whole body comes up with that arm because that muscle and the joint does not move. You can place people, if you anticipate them not being able to ever move that joint again, you can go ahead and put them in braces. They do have wrist and hand braces that you can put people in that I've seen before. They also have boots that you can put people's feet in. We can prevent things like foot drop with those boots, but we can also prevent some contractures from forming. A lot of times if patients go into long-term care facilities and their range of motion is not being done and they're not working with physical therapy or occupational therapy, even if your patient can't really participate too much in those activities, you can go in and do those things with them. It's not going to hurt them to go in and do this range of motion with them. Just remember to make sure that you're not pulling too hard on those joints or putting them past their limit, but making sure that you're giving them that good range of motion and keeping those muscle fibers and everything nice and loose, because they can end up like this patient and end up in those contractures like this. And it's very, very difficult to come out of that, if at all. Kyphosis, so this is the extreme curve in your thoracic spine. And this occurs with aging. So if you've ever seen a little old lady with like a humpback, that's what this is. So this is kyphosis. And this does just happen in your thoracic spine. Scoliosis. Does anybody remember in gym class where they used to have you go and the nurse would come and like boys on one side, girls on the other, and you had to bend over and touch your toes and they'd walk their fingers up your spine? So they were testing you for scoliosis back then, and I don't know if anybody ever told us that when we were younger, but when you later find out, you're like, oh, it makes so much sense now. And it does first show up in adolescence, the start of scoliosis, so that's why they check us when we're so young. And this is the curvature of the thoracic spine, and it can be an S shape. This comes in a variety of different degrees. Where I work, we do a two-step surgery to fix scoliosis for people. So they go in and they may have to take out some parts of the spine, and then they realign everything and put rods to kind of hold everything in that straight line. I had a woman one time, she was, I think, in her 70s, which, by the way, going for spinal surgery anywhere above 65 is always a terrible idea. But she came out of surgery, and we stood her up for the first time, and her husband goes, oh my gosh, you're at least 4 inches taller, because for her whole life and the whole time they had been married, she had been like this. So now she was straightened up, and she didn't have that S curvature in her spine anymore. So people do actually wind up becoming like 3 or 4 inches taller because they don't have that curve in their thoracic spine anymore. So your third eye clicker question. A physical therapist is working with a patient who has had a large left MCA stroke. The therapist is lifting, stretching, and moving the patient's right arm. What type of range of motion is the therapist using?
Oh, let me see. I can't see that far.
It says numeric. I don't know what that is.
It says 1, 2, 3. He's like 3.
Okay. Mine did this one. Oh, there you go. Let's try that again. Okay. Now we're in business. Sorry about that. Boy, you guys are so like attentive to that. You're like, wait, it's not the same.
It works. Yeah.
we have the answer being.
Oh, it's because I clicked the screen now,
Oh.
sorry.
Do I click in the box? Or?
You can just click anywhere on the screen and it should, now you should be okay.
Okay, so our answer is C. Do you guys remember why? When someone's doing it for you, that's your passive range of motion. Remember, active is when the patient's doing it themselves. So when a patient that has had a stroke and it's been a significant stroke, you are most likely going to see that that patient doesn't have movement on one side of their body. So this would be this passive range of motion where we are going to be doing that movement for the patient.
How often do you usually do that passive range of motion? Like if it's a stroke patient and only half their side is?
You can I would say probably like every 2 hours with your turning would be a good idea to do it. I'm actually not sure if there's a specific designated thing for it, but it wouldn't hurt to do it every 2 hours if you're turning with the patient. So you're going to go in there and turn them anyway. So, you know, you might as well just be like, okay, well today, like this side we're going to do, you know, we're going to do your right arm and we're going to lift this one up and then we're going to bend this knee in and extend it out. And then when you come in the next time, you can do the other side. So it doesn't hurt to just kind of go along with that. All right, number 4. During a physical assessment of your patient, you notice that the patient's right hand grip is strong and firm. The left, however, is barely detectable, but still there. How would you grade this patient's hand grips? Okay, good job, you guys. So the answer is D. You're going to be giving the right hand a 5 because it's strong and firm. You don't see anything wrong with that side. And then for the left, you're going to give it a 1 because even though it's barely detectable, it's still there. You're still going to see that flicker of movement in that patient's hand. So you want to give them credit for that. So you're going to give them a 1. We don't have too much more to go, so just hang with me for a couple more minutes, okay? So there are some diagnostic studies that you can do for your patients. These are things like your x-rays, your CT scans, and your MRIs. With your x-rays, just like our Kermit the Frog picture, we can only see the bones that are in the patient. One of the safety concerns that you're going to want is to make sure that your patient's not pregnant. So, you know, a lot of patients when they come through the ER, sometimes they just automatically do a pregnancy test on them. If there's not one and they're within that childbearing age, which now we know women are, you know, having children later in life, so it doesn't hurt to just ask. You know, just make sure your patient's not pregnant. With CT scans, these are going to be 3D pictures to diagnose soft tissue injury and your bony abnormalities. You can do this with or without contrast. And for the contrast, you want to make sure that your patient's not allergic to shellfish or iodine. A lot of times when patients go down for a CT scan, the CT tech down there will say, have you ever had contrast before? Have you ever had any kind of reaction? Are you allergic to shellfish? Are you allergic to any kind of iodine? When they go in and inject that, they'll say, you're going to feel warm all over your body. And it's going to start in their head and it's going to kind of rush down their whole body. And a lot of patients think this is uncomfortable, or sometimes they think that they're having an allergic reaction, but they're actually not. So it's just important to kind of educate your patient about this kind of thing. But the most important thing is that you don't want to get your patient to the CT scanner, inject them with the dye, and then all of a sudden have to be potentially having a code because your patient has this reaction to shellfish or iodine, and now you have to emergently help your patient. With your MRIs, your magnetic resonance imaging scan, this is going to do more of your soft tissue, like ligaments and cartilage tears. You want to make sure that your patient leg or something, and you want to make sure that this is going to be okay for them. If they don't know, you can go ahead and get an x-ray actually to clear them. So if your patient comes in and they're a doe and you don't know anything about this patient, before just going and sticking them in the MRI, you can clear them by doing x-rays. If your patient has any kind of claustrophobia, MRI scans can tend to be a little lengthy. I think the longest that I've been in MRI is probably 2 hours and 45 minutes with a patient. So it's very long and it's very uncomfortable for your patient, especially if you're doing things like a head and then the whole spine. That can be a lot for them, and it can be very uncomfortable, and if they're claustrophobic, they're in that tube for a very, very long time. So if they need things for their claustrophobia, you can go ahead and pre-medicate them.
Okay, I was gonna ask, so you can kind of sedate them a little bit, maybe?
A little bit,
Versed?
yeah. So you can give them like an Ativan or there's a Versed, but you want to make sure that you're communicating that with your physician. A lot of times in neuro patients, you guys know that your exam is everything. I know you guys did neuro already. This is huge, so you don't want to give them anything that's going to lessen their exam. So a lot of times I have patients in neuro all the time and they're like, no, sorry, they had a head-on collision with somebody else, they have a brain bleed. No, you can't give them anything. And it seems like cruel and unusual, but we're really doing it just to kind of help them in the future. The other things that you can do, which I have only done once in my career so far, I had to take a patient to a CT scan and he would not lay still because he had a back injury that was pre-existing and he was in a lot of pain. We actually had to intubate and sedate the patient for the length of the CT scan in order to get the imaging that they needed. So you do have options when it comes to things like that. They are worst case scenario. You wouldn't like take your floor patient, like little old lady who's like, I'm not gonna lay still, and just, you know, she doesn't, it's not gonna save her life or anything if she has the CT scan. It's just more for your knowledge. Sometimes the doctors will forego it and just say, you know what, it's okay, she doesn't need to have it, or she can come back another day, or we can do it outpatient when she's more relaxed. So they will kind of work with you a little bit on things like that. So just make sure you're advocating for your patients. And what's the most important thing with your CT scans? Allergy to what? Good. Okay. All right, so we do have a little video here. So your arthroscopy, so this is going to be diagnostic, or you can actually do some kind of repairing in there for joint abnormalities. We're going to go ahead and look at this YouTube video.
The primary pathology will be addressing will be the ACL and stability is created. Through which will drill the tunnel directly into this location.
So you can see up at the top, he's in the knee, and you can see what he's doing in there, and he's able to fix any kind of tears that he needs to fix. So it looks like he's putting like a screw in.
Precise center of the anterior ligament attachment on the figure. Okay, right in the middle of the stump of the old ligament. Now it's created the tunnel. See it comes in right here. Right?
So it's kind of crazy to see things like that. So it's interesting to see things like that. You may end up hopefully never having that, but you may end up seeing it at some point or taking care of somebody who's had that. So this is just one of the things they can do to kind of help repair any of your tissue injuries. So your arthrocentesis, has anybody had to have this or know somebody that's had this? Have you had it yourself? It's kind of crazy. Did a lot of fluid come out? Yeah. So this is like your fluid on your knee, or if you have anybody that's had like water on their knee, things like that. This is actually the physician goes in and they drain the fluid that's on the knee or a joint. It doesn't necessarily have to be any. If a patient has had trauma to that joint, it can sometimes be blood, not that regular straw-colored fluid that's there. So you can see in the picture on the other side, that's more of that blood that they're pulling out of that patient. You can have medication injected if there's any kind of infection in there. They would be able to tell this if the fluid that's coming out of the joint is very purulent. They can go ahead and test that to see what kind of organisms are in there, and then they can go ahead and put some antibiotics in there for that. And then the last two scans, you have a DEXA scan, which is a dual energy X-ray absorptiometry. This is going to measure your total bone density and mass. This is going to monitor your changes in your osteoporosis patients. So how are your bones reacting to the treatment that we're giving you? Then your radioisotope bone scan. The patient is going to be injected with a radioisotope, which is going to collect in the areas where the bones are breaking down or repairing things, basically anywhere where there's a lot of activity in that bone. And it's going to have increased uptake in osteoporosis patients, osteomyelitis, and malignant lesions in the bone. These areas are actually going to light up red when they do this scan, and they're called hot spots. And areas that don't have a lot of activity or growth in them are going to be more of a blue color, and they're called the cold spots. So if a patient has some kind of malignant lesion in their bone, that's going to glow, be bright red on that scan because there's a lot of activity happening in that area of the bone. Does that make sense? Okay. So I click for question number 5. Your patient is scheduled to go for a CT scan of the chest, abdomen, and pelvis. Oral and intravenous contrast is ordered. What is the most important nursing intervention? Everybody check this. So you're going to want to check your patient for an allergy to shellfish because they're going to be getting that contrast dye ordered. Yes, you do want to educate your patient about the procedure, but I think that making sure that they don't have an allergy to the contrast dye that they could potentially have a severe allergic reaction to is just a little bit higher than